And I would like to introduce Marc Sim. Now, Marc, you really do have a fabulous bio. Your research is endless. So please, would you like to introduce yourself? Thank you for delivering your presentation today.
No problem. Happy to share this information with everyone here. I'm Marc Sim. I'm a senior research fellow at Edith Cowan University in the Nutrition and Health Innovation Research Institute. I basically run the Falls Free Future program at ECU, and a lot of my work is centered around basically nutrition and early identification of individuals at risk of falls and fractures for early intervention strategies. But probably let's just start with the presentation, and then I'm happy to open it up for questions right at the end. So I guess this for me really sums up why I do what I do, why I do what I do, and pretty much everybody here as well. 1 in 3 Australians will fall each year. Every 5 minutes, another one is hospitalized due to a fall. Fractures are the leading cause of injuries from falls, resulting in a huge amount of patient care days in hospital. A lot of money is being spent on falls, but more importantly, the trauma and fear of falling associated with falls and fractures that impaired mobility and loss of independence are huge burdens, which ultimately can lead to depression and isolation. And this is really something that draws quite close to my heart, because recently, in about a year and a bit ago, we ran a community conversation with about 20 older Australians, and what every single person said, the number one cause of concern as part of aging was falls and fractures. It wasn't cancer, it wasn't cardiovascular disease, it was falls and fractures and the loss of independence. So it really tells us how important it is to research falls prevention. Now, we do know that there's no pharmaceutical intervention that's capable of preserving muscle function to prevent falls. Only exercise and nutrition is effective. Now, I won't touch too much on the importance of exercise, because we all know here how important exercise is for falls prevention. But really, it is only one piece of the puzzle. There's so much more to the lifestyle, including nutrition, which we need to consider. In terms of the nutrition aspects, when we talk about musculoskeletal health, typically protein, vitamin D, and calcium are the main players in this area. But there's really so much about diet that we actually don't know. And up to this very date, we actually don't have any national nutrition guidelines specific to falls prevention as well. So when we look at the Australian Guide to Healthy Eating, you can see a whole range of the 5 different food groups up on this slide. Things that we should eat more of and things we should eat less of. And when we talk about calcium, especially and protein, for example, generally most Australians do consume actually quite a large amount of protein in relation to our requirements. But the one thing that we're actually very, very low in is vegetables, which is kind of how I've geared a lot of my research program towards, which we'll talk about today. But before we can go into that, I think it's really important to highlight the big players, which essentially is vitamin D. And a lot of the work that I'm presenting here today is based on research that we've done in a large cohort of community-dwelling older West Australian women. So these women were studied over a 15-year period, where we got nutritional data and biomarkers throughout, and we've looked at falls and fractures in this cohort in a lot of detail. Now, vitamin D is one of the key players when we talk about nutrition-related factors. I will admit, vitamin D primarily comes from sun exposure. It is very, very hard to get adequate vitamin D levels if you are deficient purely from diet. But what we've generally found was that in this large cohort of older women, we needed to maintain vitamin D levels at about 65, at a minimum of 65 nanomoles per liter when we were considering fractures, and about 75 nanomoles per liter when we're considering falls. And what we're finding was that when we got to about 75 nanomoles per liter in terms of circulating vitamin D, this was associated with better physical performance as well, which really highlights the importance of maintaining adequate levels of circulating vitamin D when we're talking about falls prevention. Bearing in mind, this is data highlighting circulating levels. When we talk about supplementation, that's a whole completely different ballgame. supplementation typically is only found to be beneficial if somebody is deficient. If somebody is adequate in a specific nutrient, in general, from a lot of nutrition research, additional supplementation is not really going to make that much of a difference. In fact, in some cases, such as vitamin D, it can actually be harmful. Now, the next big player is obviously protein as well. And protein is obviously very key for building muscle, for maintaining function. As we get older, there's a whole range of things, as you can see on your slide here, which actually can compromise protein intake, your genetic predisposition, your ability to absorb protein as well, all decreases. And that is why we typically have a much higher recommendation of protein intake for older people. And we typically say somewhere around the vicinity of about 1 to 1.2 grams per kilogram per day, and at least 20 to 25 grams of high quality protein, which can come from lean fat-free animal sources as well. But again, I like to really stress that unless intake is inadequate, supplementing protein without resistance exercise is unlikely to increase muscle mass, strength or function, and lower falls risk. So again, exercise in combination with proper nutrition is really key. Now, this is probably the most amazing study that I've seen in the last couple of years. This was done by some really talented researchers in Melbourne, led by Sandra Luliano. She's a dietitian, and basically what they did was they wanted to look at basically whether if they provided dairy, by increasing dairy supplementation to older adults living in aged care facilities, whether they could reduce the risk of falls and fractures. Now, this was a 2-year randomized controlled trial, so a very high level of evidence across 60 residential aged care facilities, or just over 7,000 aged care residents, slightly higher amount of females. And what they basically did was they provided milk, yogurt, and cheese to basically enable these residents to reach the required amounts of calcium and protein a day. So about just over 1,000 milligrams of calcium and 1.1 grams per kilogram of body weight. And it was absolutely amazing to see that they were able to reduce the risk of fractures by 33%, 46% for hip fractures, and 11% for falls over a 2-year period. Absolutely outstanding. And most importantly, the reduction in risk was actually achieved in five months for fractures and 3 months for falls. So very quickly, by just improving our nutrition, we're actually able to reduce the risk of falls and fractures. Now, the one thing I will state from this trial was that this intervention of increasing dairy foods purely to meet the recommended levels would have cost an additional $1.05 per day. I've just seen the cost benefit analysis, which Sandra presented last week in Newcastle. And for $1, this is all we needed to do in order to reduce the risk of falls and fractures. If there was a medication that would achieve these sorts of benefits, we could charge whatever we want, and I'm pretty sure we would jump onto it as well. But to kind of zoom in on the other aspects of diet, which we know less of, is vegetables. And I think vegetables typically get clumped together, but really when you start breaking vegetables up into different classes, as you can see on the screen here, these vegetable classes provide a whole range of different nutrients. So it's really important to consider diversity. We know that specific vegetable types, such as your cruciferous and your alien vegetables, as you can see on the screen, is really beneficial for your heart health. But I really wanted to know whether there were specific vegetables that were most important for muscle and bone, especially because nitrates and vitamin K, which are found in very large amounts in green leafy vegetables, have been raised as potentially beneficial for muscle and bone. So to start off, we ran this study in this large cohort of older women from Perth again, just over 1,400 women. And what we found was that compared to women consuming more than 3 serves a day, those who consume less than 2 serves of vegetables a day had 31% lower odds for having weak hand grip strength and slow timed up and go. So, and these are really important because they are major risk factors for falls and fractures, which I'll show later on. These women also had 26% lower risk for a fall that required hospitalization. Bearing in mind in this cohort, the average length of stay for a fall was approximately 10 days. Again, when we looked at women with the highest versus the lowest intake of cruciferous vegetables, your broccoli, your cabbage, your cauliflower, we were seeing that these vegetables were associated with a 22% lower risk, and the alien vegetables, 26% lower risk for fall-related hospitalizations, suggesting that these vegetables provide some special nutrients that could be beneficial. But one of the other nutrients that is very rich in a whole range of vegetables is actually nitrate. And nitrate is provided in very large amounts in green leafy vegetables and beetroot. The benefits of nitrate for cardiovascular health, metabolic syndrome, and cognition have gained a lot of interest over the last couple of years, and there's been a lot of work in this area as well. But in the exercise space, nitrate has taken quite an interesting role because athletes actually use nitrate to try and actually improve their performance. So it's very common in high performance sports. So I basically wanted to know what if we looked at nitrate in older population, do we see these benefits as well? And there were two really nice studies done by this group in the United Kingdom, Andrew Cogan group, and they basically provided dietary nitrate in what I will admit is a very, very high dose. So 700 milligrams of concentrated beetroot. It's like eating 4 beetroot, so it's not practically feasible, but it's a proof of concept. And what they showed was that by providing this one shot of beetroot, they were actually able to improve the angular velocity of the knee extent of the lower limb, so in the leg, as you can see on this figure here, and the power of the lower limb as well, which again could have massive implications for falls prevention. But another really interesting study that they did was when they actually supplemented this acute nitrate to patients after they had undergone, say, coronary heart surgery or bypass surgery, they actually managed to reduce the decline in function after surgery over a 7-day period as well. So really some preliminary evidence to suggest the importance of nitrate for muscle function, strength per se. Now that's quite nice, and that's a small little study, although it's a randomized control trial showing proof of concept. But I really wanted to know how this would translate at a population level, and what if we looked at comparing women with higher versus lower nitrate intake. So in this cohort of older women, which I described earlier, about 1,425, we looked at we calculated their nitrate levels from a food frequency questionnaire. And what we found was that compared to women with the lowest nitrate intake, so less than, so total 1, and 64 is the equivalent of about less than half, really less than a quarter of a serve of green leafy vegetables a day, compared to women with the highest, so greater than 90, which is about 1 to 1.5 serve of any green leafy vegetable. These individuals had lower odds for presenting with weak grip strength and slow times up and go. So some evidence there, although it's cross-sectional in nature, suggesting that nitrate is really important for muscle strength and function as well. But we really wanted to know whether this would translate long-term into benefits as well. So we looked at dietary nitrate over a 12-year period in a cohort of about 3,000 Australians across Australia from the Oz diet cohort. So these were men and women across the lifespan. So we looked at their nitrate intake over a 12-year period, and we averaged it, and we looked at their functional measures at the 12-year mark. And once again, compared to individuals with the highest nitrate were 11% stronger, 4% faster on both the knee extension test and the timed up and go test as well, compared to individuals with the lower nitrate intake. Again, they had lower odds for weak knee extension strength and slow timed up and go. And this relationship was not affected by gender, sex, or physical activity status, which really suggests that vegetable-derived nitrate could be a very important role in supporting muscle function as we age. And like I've said before, really it only requires 1 serve per day of green leafy vegetables to get similar amount of nitrates. This is basically just a slide which sums up a very high level of evidence for the benefits of nitrate. So clinical trials, 19 of them, but I will admit this is not specific to all the populations. And when we looked at the benefits of nitrate on functional performance across all these studies, it was estimated to be about a 5% benefit with higher nitrate intake, which really highlights the importance of having a consistent habitual nitrate intake, which typically can come from green leafy vegetables. And as I've shown you before in the last couple of slides, this importance of nitrate for muscle function is so important because when we looked at grip strength and timed up and go, we know that when somebody gets weaker, especially when and that can be assessed through grip strength, or gets slower when you assess it through the timed up and go, then the likelihood for a fall, especially falls that result in hospitalizations, really skyrocket. So anything that we can do to preserve muscle function in addition to exercise is really important. And I just really like to bring up this scenario where I know in clinical practice, we like to consider cut points. If you're below or under a cut point, we treat or we don't treat. But we need to consider a situation if we consider less than 20 kilograms for, say, hand grip strength being weak, and an individual presents with 20, I think really that should raise clinical suspicion for exercise and dietary intervention to be prescribed already. However, a more alarming scenario for me would be somebody who goes from a grip strength of 32 to 22 in 1 year, which really highlights this quick decline, and that should really trigger clinical intervention straight away. Another nutrient that I like to speak about very in the next couple of slides is vitamin K. Now, I won't bore you with the name of this protein, but essentially, when we look at osteocalcin fraction, as this fraction goes up, that's typically a biomarker of poor vitamin K status. And what we found was that vitamin K, which is found very rich in vegetables and fruits, especially green leafies, when an individual had poorer vitamin K status, they had slower timed up and go performance. They had a greater decline in time up and go performance over a 5-year period. There was an increased walking aid use and a fear of falling. And when we looked at the data in the older women from birth, what we found was that as vitamin K status became worse, the risk for a fall-related hospitalization actually increased by up to 40%, suggesting that vitamin K is really important. But the problem with vitamin K is we actually really struggle to measure vitamin K, and there wasn't a vitamin K database in Australia until my amazing student Claire went out to Coles, Woolies, and Aldi, and she measured over 115 foods from the supermarkets and actually quantified the amount of vitamin K in these foods. And she created this database, which we're now using, and I'll show you how we've used in the next couple of slides. And you can see vitamin K1 is very rich in green leafies, and vitamin K2 is typically found in your dairy products as well. So in the cohort of older women, what we did was, once we had this vitamin K data, we applied it to the nutritional data that we had. And what we found was that when we looked at vitamin K intakes, when vitamin K intakes were greater than 80 micrograms per day, and again, you can get this very easily from about 1.5 serves of green leafy vegetables a day, there was a substantial improvement in timed up and go performance, as you can see on this slide here. So about over 12, maybe about 12 seconds down to just under 10 seconds, depending on how much the individual had. Now, this is cross-sectional data, so it's not causal, but there is an association. And when we looked at vitamin K1 intakes, what we found was that once we got to about 100 micrograms per day, there was actually a 27% lower risk for fall-related hospitalization over the next 14.5 years. Now, the 100 microgram figure is actually quite important because in Australia, we don't really have a guideline. All we actually have is an estimate of approximately 60 micrograms per day being enough. But really, 100 micrograms is probably where we need to be at. And we're hoping to review these guidelines. Hopefully, the guidelines will change with more evidence coming up in the next couple of years. To kind of provide you with some evidence on how easy it is to change vitamin K, what we basically did was we had 30 people, and basically we put them into 2 weeks of a high vitamin K diet. Then they had 2 weeks rest. They did 2 weeks of So 4 weeks of a high vitamin K diet, 2 weeks washout, 4 weeks of a low, 2 weeks washout, and 4 weeks of a control. And you can see the results here. And what we found was that over a 4-week period, by simply consuming about 200 grams of green leafy vegetables a day, that's about just under 3 serves a day. So not just a little bit more than half of your daily recommendations. We were actually able to improve serum total osteocalcin measure. Serum total osteocalcin, which is a marker of bone metabolism, which would suggest better bone metabolism. And we actually reduced the fraction of undercarboxylated osteocalcin, which would indicate improved vitamin K status. And this once again brings us back to the point of maybe that guideline of about 60 micrograms per day, currently used in Australia, is a bit low. And we really need to consider over 100 micrograms a day in order to maximize the benefits for bone and potentially muscle as well. Just to kind of reinforce that point, in these older women from birth, we did the same calculations of vitamin K, and this time we looked at fracture-related hospitalizations and hip fracture-related hospitalizations. And again, the same pattern was observed compared to individuals with the lowest vitamin K intake. When we got to about 100 micrograms per day, there was a 31% lower risk for fracture-related hospitalization and a 49% lower risk for hip fracture-related hospitalization, which was really, really quite outstanding for us. And I think this is really important because the International Osteoporosis Foundation actually state that there's not enough evidence for vitamin K to be recommended or dispelled when we're considering bone. And they really urge researchers to kind of investigate vitamin K in a little bit more detail. And it's really nice that the IOF actually awarded us an award for this work because we're kind of building the evidence for vitamin K in this area as well. But I mean, it's all nice and well to present the evidence for nutrition. This is just some of the work that I've done in terms of where I see the interconnection between muscle and bone, and proposing a clinical pathway which it has just been accepted for publication and should be out in the next couple of days. But basically, we really urge clinicians to consider the history of falls and fractures, whether there's any signs of compromised mobility or compromised muscle strength. If there's any suspicion at all, that should trigger a bone mineral density scan, assessment of strength or physical performance, or if possible biomarkers such as vitamin D. And really, if there is no issues, then community or self-management programs such as those found on the Injury Matters WA website could be promoted to these individuals. But if we do find any indication of any of these variables to be of concern, that really requires referral. And referral doesn't necessarily stop with just medication. It really needs to consider allied health. And some of the things that we think were really, really important are your physiotherapist, your exercise physiologist, your physical therapist, your dietitian, your nutritionist to really optimize dietary intake, and a whole range of other allied health service providers that are all absolutely critical to minimize the risk of falls and fractures. Some of the things that I just wanted to highlight, being a nutrition kind of lecture, was that from a nutrition perspective, assessing BMI and unintentional weight loss is really, really important. Low BMI, as you can see up on the screen, depending on your age, could be one of the triggers. But really, that 5 to 10% change in weight loss over a 12-month period, or over a 3 to 12-month period, is a major indication that somebody's really at risk for falls. Another thing that is really important when we're talking about nutrition-related aspects of musculoskeletal health is overall energy intake. Some guidelines here, very rough calculations on the approximate amount of energy intake, protein intake, and consider some other recommendations as you can see up on your screen. But really, where I guess where we need to move forward as an industry is the integration of allied health. So the nutritionist talking to the exercise physiologist and the physiotherapist, because all of these things kind of affect each other. And unless these things are all working together, it becomes very, very hard to optimize treatment. And another thing that's really, really key is the underlying health status, whether there's any comorbidities that we need to consider or medications that can actually affect the nutritional plan when we're talking about fall and fracture prevention as well. This is just some of the work that we are doing at the moment, and it's gained quite a lot of traction. The reason I bring this up is because on the previous slide, I have BMD there, which is really important as part of osteoporosis screening, and about 600,000 Australians undertake osteoporosis screening each year. So when we go for a bone scan, we can actually get a lateral spine image, which is used as part of vertebral fracture assessment. And from this lateral spine image, you can actually see these are two examples of an individual with on your left with no abdominal aortic calcification, and somebody with very, very severe abdominal aortic calcification. Now, this abdominal aorta is a marker of advanced vascular disease. And over the last couple of years, we've actually shown it to be highly related to a decline in muscle strength, injurious falls, lower BMD and fracture, and recently late life dementia as well. So it really is kind of one of those things that we don't really look for on a bone scan, but actually tells us a lot of information on whether an individual could be at risk for falls and fractures. So under the guidance of Professor Lewis, we actually done a lot of work in the machine learning space using artificial intelligence to read these scans. So instead of having a radiographer read this, which is very, very hard to do because it's very time consuming and it really requires a lot of expertise, we actually use machine learning to identify the amount of calcification in the abdominal aorta from these lateral spine images, which can be obtained on either an DEXA machine or an X-ray. And you can see on this heat spot here, that's essentially exactly where the abdominal aorta would be and the calcification on that image as well. And what we've recently shown in this paper here is that when we were using artificial intelligence to read these images as part of a general bone density scan, the women with evidence of vascular abdominal aortic calcification had a substantially greater risk for fall and fracture-related hospitalization over the next 10 years. So it really kind of opens up this window to opportunistic screening for falls and fractures in a population that hasn't necessarily fallen or fractured yet. And we are really hoping to integrate this algorithm into about 85% of the machines that are currently used in Australia in the next 5 years. And finally, I just wanted to sum up by giving an overview of the talk today. In this paper that we recently wrote, looking at nutritional strategies to optimize musculoskeletal health. This paper is open access, it's free, and I'll give you a link on the next slide. But really highlight that there's more to diet than vitamin D, calcium, and protein when we're talking about muscle and bone. Vitamin K, K1, and nitrate, which are derived from vegetables, may be especially useful. We require more evidence, but since vegetables are really good for cardiometabolic health, I don't see the problem in increasing green leafy vegetable intake every day. There's some evidence, which I haven't presented on in a lot of detail, if we're talking about a balanced diet, to really consider the Mediterranean diet. That could be really, really helpful. And in this paper, I actually go into a lot of detail highlighting some of the dangers or the risks associated with vegan or plant-only diets when we're considering fracture prevention. And this is something that I do worry about in the next 20 or 30 years with the substantial increase in vegan diets, in veganism, whether we're going to see a much higher incidence of osteoporotic fractures. I just like to again highlight the importance of screening for strength and mobility using a whole range of tests, and if possible, consider the importance of body composition, at least body weight or BMI, or more advanced techniques such as DEXA if it's available as well. And I'd like to really acknowledge the work of the team over the last couple of years. It wouldn't have been possible. I'm really presenting this work on behalf of them. that QR code is a link to the paper which I showed on the last screen, and that's really available. So, and that could be that's written in quite a simple way for people to kind of understand the most important aspects of diet when we're talking about false fractures in the general population. And that is me. Thank you.
Marc, thank you. That was absolutely fabulous. Thank you very, very much. I am actually just going to stop the recording and then we'll open up for questions.